Welcome to Medical Logistics 101, Pulmonary Embolism, Red Flags Not to Miss. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak with a licensed healthcare professional. My goal is to help patients enter healthcare with a map instead of a blindfold, and to explain how clinicians think through these problems in resource-limited settings. Pulmonary embolism definitions. Blood clot lodged in the pulmonary arteries, usually originating from a deep venous thrombosis, or DVT, causes obstruction of blood flow, impaired oxygenation, and strain on the right heart. Signs and symptoms: sudden shortness of breath, pleuritic chest pain, usually sharp, usually described by patients as worse with breathing. Unexplained tachycardia is sometimes seen with this. Cough, sometimes with hemoptysis or coughing up blood. Lightheadedness or syncope. Leg swelling or calf pain, which of course would be suggestive of a deep venous thrombosis. Exam findings: tachycardia is the most common. Tachypnea or rapid respirations. Low oxygen saturation on your pulse ox when you first arrive in the exam room. Clear lungs on auscultation. The lung exam should be pretty much unremarkable. Unilateral leg swelling or tenderness. I'm including this pulses and sciatica. Now, when I examine these patients, if I'm worried about a DVT, I always want to document my pulses that I see in the lower extremity. And also, I'm mentioning sciatica because oftentimes these patients will present with, if you think about the symptoms of sciatica, pain that starts at their buttock area, radiates down the back of the leg into their calf. Patients sometimes are concerned that, do I have a blood clot in my leg? And particularly if they don't have a prior history of sciatica. So again, I'm not expecting to see swelling of that calf, obviously comparing to the other extremity, not expecting to see swelling of that calf with sciatica. And of course, hypotension in massive pulmonary embolus, not something you typically see, but again, if it's a very large pulmonary embolus, it can produce hypotension for sure. Differential diagnosis mimics pneumonia, pneumothorax, or collapsed lung, acute coronary syndrome or myocardial infarction, pericarditis, aortic dissection, COPD and asthma exacerbation, anxiety, panic attacks, and of course musculoskeletal pain. Again, the exam is going to be very important here along with diagnostic tests. Diagnostics that we sometimes will obtain, certainly pulse oximetry, a low oxygen level without lung findings. That's going to raise a red flag for me. EKG really won't be very impressive. You may see sinus tachycardia. That's the most common. D-dimer, the D-dimers are one of our first go-to tests, and it's useful if the patient is very low risk. Certainly, I would say most of these patients will end up ordering a D-dimer. If it's positive, you're going to get the workup looking for a pulmonary embolus. Of course, CT pulmonary angiogram, the CT scan of the chest, that's kind of our gold standard. And if there's a contrast allergy, or some reason just you can't give contrast for that CT pulmonary angiogram, you may end up doing a test called a VQ scan. That may not be available in all emergency rooms, and that may mean an admission before you get that VQ scan. Lower extremity ultrasound, of course, for deep venous thrombosis to rule out the blood clot. And generally other tests I'll obtain, blood test, CBC, CMP, troponin to look at the heart, and of course I often obtain a BNP, which is really to look for congestive heart failure. Red flags: shortness of breath with tachycardia with no clear cause. If you don't have a history, you don't have an exam finding to suggest another cause of why they're short of breath, you need to think about pulmonary embolus. Chest pain that worsens with breathing, syncope or near syncope. They've passed out or nearly passed, felt like they were going to pass out. You don't have an obvious cause. Again, you may look at brain causes, but you also are going to look at other causes, like pulmonary embolus. Hypertension, unilateral leg swelling, of course, looking for the DVT. Recent surgery, immobilization, long travel, pregnancy, or estrogen use, all risk factors for pulmonary embolus and DVTs. And of course, a history of prior DVT or PE. Pitfalls: assuming hypoxia is due to COPD or asthma. One of the challenges is that sometimes these patients will have other comorbidities like COPD or asthma, and it is a pitfall to certainly assume that's the cause of why their oxygen level is low. Again, that's where it's important to get a history. What do they normally stay at on their oxygen level? How much oxygen do they use at home, for example, if they're a COPD patient? Normal lung exam, falsely reassuring. Again, normal lung exam is not going to rule out a pulmonary embolus. Relying on D-dimer in high-risk patients. Again, D-dimer is one of those tests. It's sensitive but not specific. It is generally going to be positive in most patients who have a pulmonary embolus, but it won't always it won't al it won't always be an instance of pulmonary embolus in people that have a positive D-dimer, because there are a number of different causes that can make D-dimers positive. It's why you look at other what they call rules and criteria that helps us kind of segregate which patients are high risk for pulmonary embolus. Missing subtle tachycardia. Attributing pleuritic pain to musculoskeletal causes. That would be a big one, particularly not considering PE in young, otherwise healthy patients. I think sometimes there's like a bias when you see a young, otherwise healthy patient thinking, oh, this is likely musculoskeletal, and forgetting to check for pulmonary embolus. This is a big one, forgetting PE is a gradient. It can be small or large areas of the lung involved. Certainly you would not wish any patient to have a large pulmonary embolus, but I would say from a diagnostic standpoint, if they have a large pulmonary embolus, a large area of the lung involved, it's probably going to produce symptoms severe enough, they're going to get the full workup, and likely the pulmonary embolus is going to be found. Small PEs, again, is particularly in someone that has other comorbidities, like say COPD, where you might be tempted to attribute that to, hey, it's just their COPD, this is probably not a PE. In reality, it could be. Disposition, high risk or unstable patients, obviously immediate ED evaluation with likely admission. Moderate risk, ED evaluation with imaging. That CT pulmonary angiogram is kind of the gold standard in that situation. Low risk patients, outpatient workup only if the vitals are stable and the risk tools, these criteria that we use to categorize whether or not the patient is high or low risk for a PE, that would potentially be okay for those patients if they were felt to be very low risk. However, the question is, who's going to order that test on an outpatient basis? If you have a PCP, someone that knows you, follows your lab work, follows your test routinely, that would be fine. However, can you get in to see them in a timely manner? That's a question. Urgent care is likely not going to be willing to order that test. And of course, confirmed pulmonary embolus, anticoagulation unless contraindicated. And the situation is not common, but where someone has a massive pulmonary embolus, large area of the lung is involved, and those patients, thrombolytics or interventional therapy can literally be life-saving. In closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you would like to see covered, you can email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can't afford to miss. Thank you.